will myeloma be curable by 2020? I'm going to say clearly yes. And actually, my discussion will be over in the first 4 slides. But I'm going to show you some additional data about why I think that that's even more true. So let me set some definitions, some ground rules, because these are always important. I'm sure Antonio is going to try and change the rules and change the words and what they mean. So I'm going to define them here. So extremes, we're not curing anybody, we're curing everybody. Those are probably not ever the answer. Not all patients with myeloma have exactly the same disease, and so identification of these differences are important because we probably need different strategies if we're going to effectively cure them. And again, these blanket statements are not going to be able to be applied to a disease as heterogeneous as myeloma. So, what are the definitions? Cure, if you look it up in Webster, is to get rid of or to heal. And I think that's an important message here, to heal. But there's a difference between how it's defined and how people think about it. People think cure means it's no longer there. Do you ever cure a patient with hypertension of their hypertension? No. But you can control it, you can heal it, and patients can live long lives with controlled hypertension. So that, to me, is an important difference between the definition and the connotation of cure. Incurable, not likely to be changed or corrected. Well, I would argue that every time we treat a patient and we get a response, we are correcting them. So the definition of incurable probably doesn't fit. But people interpret that as fatal, no hope, limited options. I'm leaving that to Antonio. What about chronic condition? Again, a chronic condition is a condition that lasts for more than 3 months. It's a condition like hypertension or diabetes. And again, I will argue that what I'm going to show you fulfills the definition of cure. And the question is, when will we get there? So, what do we know in 2014? Well, we know there are patients who do very well for a very long period of time. There are patients who have a very short battle with myeloma, who one will define as high risk by one definition or high risk by another definition, and they often die of progressive disease. And as we've heard very nicely, there is clonal heterogeneity amongst a group of patients who have a genomically unstable disease like myeloma. And that's what I think is really important to remember. The genome in myeloma is supposed to be unstable. That's what gives us the kind of immunoglobulin diversity that we need to survive. And as a cancer, myeloma cells take that inherent genomic instability and take it to the next level to allow them to evade normal mechanisms of control. So, I will argue, and this is the slide that I think I should just stop after this, that we're already curing patients right now. This is data from the Pathema group with almost 15 to 20 years of follow-up. And as you can see, there are groups of patients here that are living in what looks like a plateau in either a CR here, progression-free, and overall survival at about 10 to 15%. And this is with interferon as maintenance therapy. We didn't even talk about interferon as maintenance therapy in the last session here, because the use of alkylators, the use of high-dose therapy and autologous transplant was able to convert a small fraction of patients into what I would call long-term disease-free survival, or in this context, I will say that these patients are cured. So I think, yes, we're going to cure them by 2020 because we're already curing them now. And unless we go backwards and stop offering patients effective therapy, this number is only going to get bigger. Now, if you come from Arkansas, you've been arguing for decades that we've been curing myeloma. And in fact, this is the long-term survival curve for patients who receive total therapy 1. You can see he will argue here that this number is closer to 35%, which is actually even bigger than the Spanish data that I showed you before. And again, if you start to look at TT3, TT2 with thalidomide, there are plateaus, although the follow-up is not quite as long, but there are fractions of patients who have been functionally cured of their disease. I was talking to Dr. Ludwig earlier today. He tells me they have data from Austria that says patients who get consolidated with an autologous transplant with therapy circa 1990s, he has a similar plateau on his curve as well. These patients exist in all of our clinics. And while every speaker in the last session said myeloma is an incurable disease, I don't think that's true. I think we are curing a certain fraction of patients. The question is, how can we make that fraction bigger? That's really the challenge for the next 4 years. So what are the steps needed to increase that? Well, obviously, aggressive combination therapy. If you want to eliminate the idea of clonal evolution, eliminate the tumor. That's the most effective way to eliminate clonal evolution. And introduction of trying to get patients to lower levels of MRD, because you can't really cure a patient if you don't eliminate all their disease. In terms of the next 6 years, which is the time frame that was given to us in this debate, new targets and addition of mutation-based agents are likely how we're going to get there. And I'm not going to go over that in a lot of detail. I'm just going to show you a little bit of slides, a little bit of information on that. So the potential for cure is dependent on effective therapy at the time of diagnosis. If you undertreat a patient at the time of diagnosis, you are asking for clonal evolution. You are asking for the disease to morph itself and become more resistant. So the idea of the let's do no harm, I think, is an error in myeloma therapy in 2014. We need to do whatever we can to eliminate as much of the disease as we can in the first shot we get, because that first remission is often the longest remission. It's when patients have the fewest number of acquired mutations, and it's the best shot at long-term cure. And again, the idea of undertreating at diagnosis may make the idea of clonal evolution worse. So this is data that Ajay Nuka from our group published in our series, and these are patients who got effective 3-drug induction therapy with RVD, and this is their survival curve with a median follow-up of close to 4 years now. Now, all these patients received RVD. I'm going to show you data that says risk starts to go away when they get effective induction therapy. So if you're able to avoid alkylators early on in the course to a genomically unstable disease, and then you give aggressive maintenance therapy for high-risk patients, you can make those curves start to come back closer together. That's ultimately the best way to reduce clonal evolution: effective induction, effective consolidation, and effective maintenance. And I would argue that maintenance should be based on what the genetic and genomic risk is at the time of diagnosis. But you shouldn't shy away from treatment at the time of diagnosis because you think a patient is potentially going to do better with less therapy. So, what about the idea of getting to MRD negativity? Well, we talked about stringent CR, we talked about complete remissions, but the reason that many of these studies that we talked about in the last session as well suggested that depth of response does not always correlate with improved clinical outcomes is that they're not taking into account this level of MRD negativity. And if you look at Antonio's own study, where patients either had a transplant or didn't, the improvement in progression-free survival occurs favoring a transplant even though the response rate is the same. Why is that? Because more patients in the transplant arm achieved an MRD negative remission. That to me is really important. The idea of not being happy with this, but driving patients to try to get to lower and lower levels of disease burden is something we have the technology to do right now. And we can do that now and alter potentially our therapy. So consolidation with VTD by PCR showed an improvement in progression-free survival, and there certainly are trends in overall survival for these patients as well. If you start to look at multi-parameter flow cytometry, again, big differences in progression-free and overall survival favoring the group that achieved a multi-parameter flow negative remission. And in fact, if you look at just patients in CR, just the best of the best, big differences again in progression-free and overall survival favoring the group that achieved an MRD negative stance using multi-parameter flow cytometry. Now, do I think that this is the ultimate answer? I don't. I think that actually the newest sequencing-based approaches for assessing MRD will give us two pieces of information. It'll tell us about who's MRD negative, and for patients that are MRD positive, it will allow us to target that residual disease with mutation-driven treatment. So you get sort of two bangs for one buck, if you will, if you use sequencing as your approach for assessing MRD. But the idea of ignoring outside the marrow disease is a mistake. I think Bart told this to us 10, 15 years ago when he first began to isolate focal MRI lesions in the bone that may not show up because of sampling errors in the marrow. And the idea that we're going to just declare CRs or victory based on a marrow itself is no longer acceptable. And as you can see here, big differences in outcomes based on PET scans. And in fact, if you even look at the CR patients, patients who are negative by PET scan will do better than patients who are positive by PET scan, even among complete remission patients. So Antonio's going to say, even with MRD negativity, even with PET negativity, those curves have not plateaued. Patients are still relapsing, so they're not cured. My argument is, if you use each of them independently, that's correct. But if you put them together and say that a true CR has to be radiographically and sequencing or multi-parameter flow negative, you're going to get a smaller number of patients, and that should be the target that we seek for these patients. Not just saying one modality or another, but we have to put them together to ultimately be able to get to this road. So, what are the next paths, the steps in the path to increasing the cure in the next 6 years? Antibodies, mutation-driven targeting, and pathway-driven targeting. And I'm not going to go into a lot of these drugs, but I want to introduce this concept that some of you may have already heard from my colleague Larry Boyes, who's created something he calls the tau of myeloma. And it's this idea that most of the drugs that are effective in myeloma actually follow on the normal biology side of the tau. That the drugs that actually we've used and have not been effective have tried to target tumor cell biology. The only one of these that's really worked has been BRAF inhibitors, because we know that's a very small subset of patients. So if you want to cure patients, the whole concept of personalized medicine and cure in myeloma, you can't rely just on this, because you'll be missing all this stuff on the side. Cereblon expression in normal plasma cells is the same as it is in a malignant plasma cell. PSMB5 expression in a normal plasma cell is the same as it is in a malignant plasma cell. We have to pay attention to normal biology in conjunction with using targeted approaches in the mutation or tumor biology side of the piece. So, what are the drugs we can get there? Well, antibodies, I think, are something we're very, very excited about. SLAMF7, which is something I'm going to talk about tomorrow, the target formerly known as CS1, for those of you who are Prince fans. CD38 has 2 drugs that are going after it. Daratumumab is probably the furthest along, but Sanofi has a drug, CD138. Mutation-driven, right now the only drug we have is the BRAF inhibitor, but there are probably others that are down the pike for NRAS and KRAS. And finally, pathway-driven, overactivation of PI3K may be targeted through AKT inhibitors, nuclear transport inhibitors, and then PI3K isoform inhibitors as well. These will help us to increase that fraction of patients who were cured by 2014. But again, in summary, we are already curing myeloma right now. So the debate's over. Antonio, you can go to dinner early if you want. If we want to increase the cure fraction, we need aggressive induction that reduces the opportunity for clonal expansion, focus on MRD testing with both biology and imaging to get us there, and then use these new drugs in the context of maintenance or MRD to try and drive the disease away, ultimately with the greatest chance of cure.